welcome to the Critical Care Obstetrics podcast. My name is Suzanne McMurtry Baird. I'm the Nursing Director at Clinical Concepts in Obstetrics. I'm joined today with my partners, Dr. Stephanie Martin, our Medical Director, and Julie Arafeh, our Simulation Director at Clinical Concepts in Obstetrics. Today, we are on our third episode of responding to questions from our listeners. We got so many that we're trying to cluster them together into certain topics. So today, we are going to answer some more of the topic headlines that you are asking for, and we also want to say thank you.
I just want to let our listeners know we have another guest joining us today, and that's little baby Dolly.
Yes. Not by choice.
Dolly is Suzanne's adorable boxer puppy who really wants to be part of the podcast. So you guys are going to hear her in the background, and I wish you could see her. Someday soon you'll be able to see her, but wish you could see her. She's absolutely adorable. And
well, you can see her on our social media sometimes, but she is scratching and snorting over here with a toy. So I apologize in advance, and especially to our producer, Austin Baird, who is going to go nuts when he starts hearing this background noise.
That's okay. She just wants to learn all about all the viewer questions.
Well, I know. I think she's starting to learn it like my husband, you know. He knows all about labor and birth. Of course, his mother was a labor and delivery nurse as well, so.
Oh, I have to tell a story there. We were at a conference Well, hi, Dolly. Suzanne and I were at a conference in Las Vegas. We were speaking last weekend. There was several hundred people there, a lot of nurses, physicians, midwives, everybody. And one of the nurses that I used to work with in Colorado Springs was there with her husband. And she had sent me a message and we were talking about it. And she says, I want you to introduce you to my husband because he now knows everything about preeclampsia because he listens to these podcasts with me in the car, and he recognized our voices, and we had a great time catching up. So that was that just made our day. Like that a non-medical person now understands preeclampsia and hypertensive disorders, you know, from listening. So you don't have to be medical to learn something that's interesting on this podcast, right?
That's right. My goddaughter listens too. Shout out. Hey, Cody. She listens to all of ours podcasts.
Well, today we're going to be digging in. One of the big questions that we got from people was telling the difference between an amniotic fluid embolism and a pulmonary embolism in real time. That's a real challenge clinically. You know, often these patients are either in shock or in cardiac arrest at the time they present, and you start going through your differentials, your H's and T's, and you immediately start thinking about, hopefully immediately start thinking about the possibility of an amniotic fluid embolism, and PE are right there at the top. So I thought we'd kind of talk through, you know, what are some issues or some key things to remember when you're trying to distinguish whether somebody's got an amniotic fluid embolism or a PE.
Yes, it can be really difficult because they look so similar, you know, when they present. Both patients may have, I don't feel right, or I may have a premonition that something bad is going to happen. And I've seen that in both AFE as well as in PE. And they may then become acutely short of breath and acutely unresponsive, depending on the size of the PE, and acute onset of hypotension. So they present very similarly when they start complaining of symptoms.
Yeah, and I want to point out that a couple things. First, PE is vastly more common than an amniotic fluid embolism, number one. Okay, so it should absolutely be on your differential. The majority of pulmonary emboli are not going to result in catastrophic situations like cardiac arrest or shock. The majority are going to be hypoxemia, shortness of breath, anxiety, tachycardia, those type of more definitely abnormal, but more subtle, not as dramatic as a cardiac arrest situation or a acute onset of shock situation. So I want to point out that here we're kind of highlighting the most dramatic pulmonary emboli, the ones that result in severe sudden onset hypotension or cardiac arrest, and then the kind of the classic presentation of an amniotic fluid embolism.
Right, because the larger the PE, the more symptoms they have. And if they go into cardiopulmonary arrest, it'd be a pretty large embolus that would occlude forward flow of blood and oxygenation. So, and because both of them also, if you were to do an echocardiogram, both of them appear with the same kind of intracardiac pressures as well as the appearance of right heart strain, because in AFE you have acute onset of pulmonary hypertension, severe, to where forward flow of blood is stopped initially or slowed tremendously, and therefore cardiac output drops. In a PE, obviously, if it's a smaller emboli, then you have less symptoms. A patient, like Stephanie just said, may just complain of shortness of breath or really become tachypnic and hypoxic. But again, the degree of those symptoms in PE is really dependent upon the size of the emboli. And then they can have right heart strain as well. If you look on an echo, so much so that sometimes even the septum in the heart and the ventricles can even bend towards, the left side, pushing out, because you're going to have so much volume in the right side of your heart. It's almost like a right heart failure, which I hate that word, but right overload, because it's not going forward, and that's going to drop your cardiac output. So they're very similar in that way. And the other thing that we have to think about is in AFE, the one major difference is that those patients will have DIC. So to determine that, and it's a consumptive, like it's not they bleed first and then you're seeing the bleeding at the time and then they develop DIC. This is they're developing DIC and you don't have any idea that they're going to be hemorrhaging at that point, right? It has not started. So the hemorrhage is a little bit delayed in AFE, and PE does not have DIC.
Yeah, this is a really crucial point, because when let's say your patient is in cardiac arrest and you do the resuscitation, you're able to get return of spontaneous circulation, okay? Now you've got to start trying to figure out, why did this happen to this patient at this time? It's what Julie preaches all the time. Why did this happen to this patient at this time? And so you've got AFE and PE at the top of your list, especially if you're using a checklist to kind of guide you through all the different possibilities. You're not going to forget either one of them. But the classic criteria for the diagnosis of amniotic fluid embolism is that it happens within and around childbirth. You've got sudden onset of hypotension and respiratory failure or cardiopulmonary arrest, plus DIC, and that happens before hemorrhage, plus no fever. So PE, you're not going to have a fever. PE, you're not going to have DIC. Yes, it is a clot, but it is not consuming all of your clotting factors to the point where you have used them all up and are now in DIC. That doesn't happen. And you can absolutely have cardiopulmonary arrest or sudden onset of hypotension and respiratory compromise. So that's where the confusion comes in. You can't diagnose a PE in the moment. You can't. You have to suspect it, because the way you diagnose it is imaging of the chest, and you've got to have the patient get stable enough to do that imaging. So you're going to have to have a working diagnosis when you're going through this. And really the question that makes everybody crazy and stressed is, do I need to acutely treat the pulmonary embolism with thrombolytics? Because you're not, with an amniotic fluid embolism, there is no magic bullet. You're going to have to be doing your regular supportive care, offloading the right heart with medications like milrinone or dopamine or something along those lines, and then considering ECMO if they don't get better. But with a PE, you're going to be considering whether you need to give thrombolytics. So key thing, do they have DIC? if they're not bleeding and having visible evidence of DIC, then you're going to have to draw labs. So please draw labs before you give thrombolytics. And then if it's not clear, you've got that extra piece of information to help you after the fact.
And key point on the labs, we're really looking at our fibrinogen, because D-dimer is going to be elevated in pregnant patients. Same thing with fibrin split products, but that is a process too, and they're going to be elevated. So if you're looking for differential key components, fibrinogen is going to be a real key, because that is your ability to form additional fibrin clots. So also know that PT and PTT will not be prolonged until your fibrinogen is really low in critical stage for a pregnant patient. So again, fibrinogen will be really key in telling whether this patient's going into DIC.
Julie, I want you to talk a little bit about, your perspective on this, because, I think especially for me, having that checklist in this acute situation, like what the heck is going on? What are your thoughts?
Well, my thoughts are the checklist needs to have these labs listed, and potentially so that when you're at this situation, you're trying to make this decision, AFE versus PE, you have a very clear understanding of what the labs are. And it may be that you even get even more granular than that and say, we need 2 red tops, a lavender, and a green, or whatever it is, and have the exact labs in there. And you may even have that as an automatic part of your checklist, that whoever is in charge of meds or drawing labs just lets the physician know, I have drawn these labs according to the checklist. Are there any other labs you would like in addition to these? So that you have those results coming back, and that is another piece of information the physician has in making their decision.
Yeah, and just to piggyback on that lab comment, if you think it's possible that it's an AFE, please collect samples for the AFE Foundation. Just draw blood. I think it's a red and a lavender top. Set it aside, yes, and contact the AFE Foundation. If it's not an AFE, you can toss it later, but that's a crucial piece. But sorry to interrupt. I just wanted to piggyback on that.
No, I think that's very important. And this is one of those situations where in simulation, when you're practicing this, it's a great time to talk as an interprofessional team. What is the physician going to need to make the diagnosis, and or to differentiate between these two as best as possible? And you may also have most common first steps for both, so that the team in the room can anticipate what's going to be ordered next.
Yeah, and then I wanted to talk a little bit more about treatments. Okay, so one of the big questions we got, and I guess I'm surprised and not surprised all at the same time, that every time we talk about amniotic fluid embolism, and even when we're not, we get asked about AOK. So AOK, I have a whole podcast on it. We talk about amniotic fluid embolism in many, many episodes. I think we have 4 or 5 episodes on amniotic fluid embolism, because this is such a hot topic with our listeners. Everyone's fearful of this. So go back and listen to them. But the bottom line is AOK is not supported by science. We don't think it's standard of care. We don't think it should supersede anything else going on. There's really no evidence that it's beneficial in the management of AFE. Focus on the 3 Bs, bleeding, blood pressure, and breathing. Fix those, address those, and that's your best chance of saving this patient.
Yeah, I think a lot of people, again, the 3 Bs or so need to be highlighted, and it needs to be highlighted also in your training with your team, because I think everybody they feel really confident in, for example, the bleeding part, the hemorrhage. But when you practice, and sometimes when you practice together as an interprofessional team, we realize we're not really managing that the best that we could, right? And that we have a lot of opportunities still even just with that 1B of hemorrhage and bleeding. So I think that's key, that you start to think overwhelmingly about those 3Bs, and we've got work to do even with the first one.
Yeah, Julia, you were telling us a story recently about a team that you worked with where they were very convinced about their performance until they saw their performance actually in simulation. Why don't you tell that story?
Well, this was a very advanced nursing team. And, one of the things that labor and delivery nurses pride themselves on is getting the patient back for a stat C-section as quickly as possible. And there were various boasts, less than 5 minutes. I know we did it in 2 minutes the other day. So I was working with a team, and we just decided one day in sim to see. So we told the teams, you're in the room, go back as fast as you can. Not one team made it in 5 minutes. And the one team that got the closest, I don't even want to tell you what all was laying on the ground being drugged behind the bed. So these 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 types of intricate, complex, lots of things having to be done at once, it's best if you can video record them. And I know everyone hates to be on video. I hate to be on video too, but you can't remember as accurately as you can watch it on a video. And you'll pick up little tips. And I remember in this particular situation, we picked up 2 or 3 things that a few of the nurses did that no one else was doing, which were totally fine things to do, that really shaved about a minute to 2 minutes off of the whole process. So these types of intricate, complex management times in the emergency really is helpful if you can video record them and really get down and analyze what you can do to smooth out that process.
Right. And again, that's all happening at the same time that the patient is having difficulty breathing, or you may be coding the patient, or, that blood pressure's down and they're wanting meds that you don't commonly have on your unit, and you're not comfortable administrating. So, that's all at once. That's why all of this needs to be practiced ahead of time, and so that your comfort level can get enhance that. Stephanie, you want to talk about thrombolytics and management of PE?
Yeah, if you've got a pulmonary embolism that's enough to cause shock or cardiac arrest, then the conversation about whether or not to use a thrombolytic is going to be on the table. And basically, anticoagulants, heparin, low molecular weight heparin, Xarelto, all of these medications, they stop further clot formation and allow the clot to be dissolved and broken down and reabsorbed. Thrombolytics destroy the clot. So when you have a clot that's big enough to impede circulation, that's life-threatening, then an anticoagulant is going to keep it from getting bigger, but you need to actually dissolve it. And so if you've got a clot obstructing circulation, you're either going to be dissolving it with medications or removing it surgically. I've had patients with both scenarios, and that's not, as an MFM, that's not my decision. My decision is involved around, resuscitation of the patient, resuscitative cesarean, which we're going to talk about next, and then the critical care team, the pulmonologist, the surgeon, the CT surgeon, whoever, they're having conversations about what they think the best approach to acute management of this is, and then we're all deciding together what we think is the best approach. That's beyond the scope of what we're going to talk about here. But in the acute situation with AFE versus PE, it's often, do we give thrombolytics because this PE is creating such a difficult scenario? And these medications have a lot of side effects, acute bleeding. They're very risky medications, so it's not something you want to give lightly. This is not Lovenox. Lovenox you can give without really having to worry too much about the risks to your patient. It's a pretty safe medication in the big scheme of things. Thrombolytics can have some life-threatening complications. They're fairly significant medications. So it's not something you just go, oh, let's give it just in case it's a pulmonary embolism, unless you're really backed up against a wall. So you really do want to make the effort to determine whether or not you have an AFE and if your patient is in DIC. So draw these labs. In fact, and that by labs, I mean fibrinogen. That's what you need to know. Does she have DIC or not? What's her fibrinogen level? In fact, in one of these AOK publications, there's only 3. And in one of them, where they say AOK worked to save this patient, the patient clinically presented as if she had a pulmonary embolism. They continued to get ROSC, and then she would go back into arrest. And they gave a thrombolytic without ever checking to see if the patient was in DIC. And even the labs after they gave the thrombolytic were not as bad as you would typically see with an AFE patient. So in my mind, this was more consistent with a pulmonary embolism and not an AFE. So draw your labs before, even if you're convinced you have to give a thrombolytic, figure out if she's in DIC before you give the labs. Once you give a thrombolytic, it's going to impact your clotting factors and your lab results.
Which affects your system of how you're drawing labs and where you're sending them. And a lot of these labs, again, can be done at the bedside with a handheld meter. So, if you're in a code process or in a emergency where you are still drawing large tubes of blood, taking your gloves off, running over, printing out the slips, getting the order entered, sending it off down the tube system, waiting for an hour to get it back, even if it's stat, having someone to call you or you have to look it up in the computer, that's going to delay your management in these patients. So you have to have a system to where you can get labs quicker.
I think that's a perfect thing to simulate, Suzanne, because you may be doing point of care testing in labor and delivery units. You may not be. If you are not currently doing point of care testing in your labor and delivery unit or postpartum unit, then coordinating and getting a sense of urgency with the people who are doing the point of care testing. Does that mean you call a code? If you just need point of care testing emergently, how do you work it out with that other department so they know that when you call, it's urgent and you need to come right away? So all of those things can be worked out and that process worked out ahead of time. It'll go much more smoothly than when you have to actually do that the first time.
Right. And it's so helpful. Like we've all been there. Like I know as the nurse and the surgeons are continuing the surgery or whatever. But the nurse who's circulating or the nurses who are circulating are running around the room getting and it may be anesthesiology department that's handing you off these tubes and saying, hey, here, go run these. And that is a huge process and it takes too long and it's too cumbersome. And we just need to hit the easy button and figure what that is in each of our hospitals before it happens. Why don't we go ahead and move on to our next topic, which is code blue and perimortem C-sections, and really focusing in on those first 5 minutes that the OB team will be managing this patient. And I would dare say more than 5 minutes because we filmed a lot of code responses and it takes a little while longer sometimes for some code teams to get up to OB. And find where they're supposed to go.
Yeah, I mean, you can't really talk about AFE and PE without a natural segue into, cardiac arrest. I just wanted to talk about terminology for just a minute. We used to call this perimortem C-sections, and we included that terminology here because that's how the question was asked. We got several questions asking us to talk more about code blues and perimortem cesarean. But perimortem cesarean to me implies that you're going to be unsuccessful, that your patient is going to die, period. And really what we're trying to do is resuscitate the mom. So there's been a big push lately, and you'll see in the literature a lot more terminology around resuscitative cesarean, because that's really your best opportunity to resuscitate the mom. We will still go back and forth, and because it's hard to change practice, we'll still say perimortem C-section or whatever, but resuscitative cesarean is really what we are advocating that we call it, and kind of what you're going to see in the literature. But I think Julie is the perfect person to start this conversation. So Julie, maybe highlight, Everybody's afraid of this happening, of course. It's why we get so many questions about it. And all the OB teams have to be prepared for that initial, at minimum, 5 minutes before they've got some support. So I want to hear your thoughts on what that first 5 minutes should look like and what OB teams really need to be focusing on.
Well, as you said, it's everybody's worst fear. I think the only thing that comes close to it is if you bring a ventilator onto labor and delivery. Those two things, just strike fear in the heart of a labor and delivery nurse.
Same scenario in the ICU. You bring a fetal monitor on to an ICU or to an emergency room, and you're going to strike fear in those providers too. So shout out to y'all that are listening.
Or worse, a baby warmer.
Oh yeah, baby warmer. Baby warmer in the ICU is...
And that little bitty ambu.
That scares me. I don't know about... that scares me. I am not a neonatal person, so that's the part that scares me. But anyway, go ahead. I digress.
No, it's a perfect segue because it's very anxiety provoking. It's not something we do very often. So this is where role delegation is crucial. Looking at the whole 5 minutes overall is frightening. And I don't know about you, but I'm getting ready to move to a new home. And I can tell you the first time I went into my garage, I was so overwhelmed to clean it that I didn't even know where to start. And I think that's exactly what happens in a code situation. There's so many things you have to do. And there is, on top of that, this urgency that this person's life is hanging in the balance. And what you do next can really impact if that person comes back. When that is a pregnant woman, it is just so difficult. The anxiety and all of the things that have to be done are overwhelming. When you break it down into pieces, it's much easier to tackle. I can give you a perfect example. We were practicing a simulation in one of the hospitals I was working in, and we had a code leader there. And the code leader said, as soon as the OB gets here, we can start the resuscitative C-section. Well, we all knew the OB was here, but the OB was so uncomfortable. And the OB was just standing in the back, really didn't know what to do. So when you take these first 5 minutes, and I'll just take the example of the obstetrician. What is the goal of the obstetrician in a code? Left uterine displacement, in my opinion, and preparing for the cesarean, the resuscitative cesarean. If you have never had ACLS, and some physicians, OBs, I don't even think have BLS, there's no way you can expect someone who has never had that education to get you through a code. Most of the time, if you've got an anesthesiologist in the room, they're going to be the ones leading the code and managing the airway. So by giving people very direct tasks, so if I'm talking to an obstetrician coming in who has no BLS or ACLS, and I basically tell them, when you come in the room, you are going to do left uterine displacement. You're going to figure out how you're going to do a C-section, at resuscitative C-section. At 4 minutes, you're going to ask for you're going to get all the stuff you need. At 4 minutes, you're going to start that resuscitative C-section. And then your task after that, after you've stabilized that incision, your job is to go and talk to the code leader about why this happened to this patient at this time. When you give people a very set of tasks, a very specific set of tasks like that, it's much easier to go in and perform at the level that you want to perform in those types of situations.
Julie, I think that when we practiced with one of the teams, I really was impressed with that deliberate practice that you did with the team. I really think that really made them more confident in their skills of what they needed to do during those first, 5 to 8 to 10 minutes. That I remember after just saying, we really need to do this every time because we feel so much more confident in what our number one, our role is, but the tasks that we needed to complete because they did them over and over again.
Yeah, I having been in these scenarios many times, it's a relief, too many times. It's a relief to really just know that somebody's got this. Like I, as the doc, I can come in and do my specific tasks, but I don't have to worry about the airway. I don't have to worry about doing compressions. I don't have to worry about, placing the pads. These things are choreographed and going to be handled. And, it just kind of came to me when I was, for many years, all through, I don't know, my whole teen years, junior high and high school, I was in marching band and I played the flute and piccolo. And we were a very competitive, large, there was about 250 people in the marching band. And we did, very intricate. Those of you listening, there's probably a lot of other fellow band geeks in the audience listening, and Julie included. And we all remember, those early mornings, learning your part in the formation and doing these very complex maneuvers on the marching field that were just from the stands look insanely impossible. But it starts with each individual person thinking about nothing else except where they're putting their feet. I'm going to be marching to this yard line, and then I'm going to do this step, and then I'm going to turn that direction. And you don't have to think about what your neighbor is doing other than you're next to them. You have to be in line with them. But you're not worried about the drums. You're not worried about anybody else. And everybody's tiny role is hugely important and impacts the others. If you're not in your role and doing your role perfectly, it's very, very visible. But somehow it all comes together because everybody's doing their individual piece and not worrying about what the other people are doing.
So when you're thinking about cardiac arrest, the foundations of cardiac arrest are chest compressions and ventilations. And if you're not doing those correctly, optimally, you are not giving the patient the best opportunity to reverse. So that's one thing that I think is the cornerstone. And this is where a lot of people don't like metrics, but these are where metrics help you so much. If you're doing chest compressions, you want to know that those chest compressions are accurate. So there needs to be some type of a feedback mechanism either on your defibrillator or what some places have are CPR coaches, someone who is watching and making sure that you're doing this correctly. And definitely think about who is doing chest compressions. One of the studies that I was involved in, we had all of the labor and delivery nurses doing chest compressions, and some of them just couldn't do them, either because they had a back injury or they had a wrist injury or a shoulder injury, which as you get older and you're working in labor and delivery are very, very common injuries. So knowing who can do those chest compressions and having that whole process down of those first 5 minutes is crucial. So, as Suzanne said, deliberate practice is a way to do this. And I won't make this about deliberate practice, but just in an overview very quickly, it is a way of walking and talking through a scenario, including what information do you need and when do you need it and who do you need it from and what do you need your area set up to look like so that you can maximally perform the task that you've been set to do. You can get all of that worked out ahead of time, and then when you go into the simulation, you can practice it so that you're actually practicing correct procedure and correct tasks and correct actions instead of going in without this preparation and just doing what you think is the right thing. There is no way you're going to know. We don't do codes, thank God, all of the time in OB. So this is a rare event. So we need to practice ahead of time before you go into the simulation.
I know, Julie, there's some key points for pregnant women that you want to make sure that you accomplish, or the OB team accomplishes during the time that they're there by themselves with the without the code team from the hospital. Can you just go over those, like 1, 2, 3, 4, or what those metric? I know you measure them with metrics, but what are those key things that you want the team to know?
Well, and just to kind of give some just a tad bit of background, when you look at what the American Heart Association has with they Get with the Guidelines program, they have a list of criteria that they evaluate the performance of a cardiac arrest against. So that's where I'm pulling this from. And for the most part, you need to be on the chest within a minute of established pulselessness. And that, of course, is very easy to accomplish. Um, you need to um, have the crash cart in the room and be diagnosing the rhythm within 2 minutes. That's a tough one. You need to be giving medications every 3 to 5 minutes, and that first medication is epi. So for OB teams, I tell them, think about epi. Know where it is in the code card. Don't think about all the rest of those medications when you're practicing, because hopefully the code team will be there by that time. So know epi, how to give it, how to administer it. And then lastly, you want to start the C-section or the resuscitative C-section around 4 minutes. This is a monumental ask in a code. And many times, even when you look at successful fetal and maternal resuscitations, that resuscitative C-section is a little bit delayed from that 5 minutes. 5 minutes is our goal. And that's what you should practice towards, because you do want to go for that 5 minutes. But if you miss that 5 minutes, don't think the procedure is not going to work, because it can still be very beneficial to the patient. But our goal is to practice to the point that we can get that baby out within 5 minutes.
Yeah, and there's lots of things that can get in the way and that we see and that I have seen get in the way of trying to get this baby out in as timely a manner as possible. First is access to the things that you need in order to do the actual procedure. So we advocate for taking a placenta bucket, the white container with the lids. They're usually a little bit tall, and put what you need in that on your code cart, and it lives everywhere in the hospital. That's part of it. In our opinion, that's the most efficient way to get what you need. What do you need? You need some sort of sponge pack or towel, doesn't matter. You need scissors, something to clamp the cord, so either clamps or cord clamps, and a disposable scalpel with the blade already on, usually a 10. That's what you need in there. You don't need anything else. Sure, you can have a needle driver, you can have suture, but the basic stuff you need is that. You don't need a gown. You're going to have gloves on. Typically in these scenarios, everybody walks in with gloves on. You're not prepping the belly. You're not moving the patient. This is remove every obstacle to getting that baby out in a timely manner. And then once the baby's out, then you've got something to put the placenta in, and then you can close the uterus in a very rudimentary fashion, and then you breathe and you wait and see what happens. Okay. There's no hurry to get her to an operating room or to close the belly or anything along those lines.
Or to start anesthesia, or to, do some of these other things.
Yeah. If you need anesthesia, you're not doing a resuscitative cesarean. You're doing an emergency cesarean, and that's a whole different scenario.
Right. I think of the other two things that we see missed a lot of times in resuscitative cesarean is left uterine displacement. And that takes one person. And then the backboard, And so again, in deliberate practice, you can have those skills appointed, those roles, and to include those to left uterine displacement is often missed.
Yeah, I think it's ideal. One of the physicians I worked with in simulation actually came up with that role for the OB, because in her mind, that's what she felt the most comfortable with. And she went right in, did left uterine displacement, and got ready to do the resuscitative C-section. And, when she voiced that, it was kind of like an aha moment for the rest of it. So, like, yeah, that's the perfect role for the OB. That is exactly what they know and exactly what they should be doing.
And it puts them in position to be ready to do the cesarean, because there is just not enough time for the OB to be doing another task and then get into position and get ready to do the cesarean. You just don't have enough time for all of that.
Well, and oftentimes, there's so many people around the patient. So you've got to have those specifics, kind of like your band role. You know exactly where your feet are supposed to be, and you know the role that you're supposed to play, and that's what we really want to strive for.
Actually, one of the trauma teams that I observed their practice, they had feet on the floor in the room, and feet meant this is a person's here and all the things they needed to do their task. So that those feet were associated with the task. All the supplies to do those tasks were right there. And I just thought that was brilliant.
Is that your heels on?
That's where you came up with the zones, and that's what's so effective, right?
Yeah, your heels on the yard line. Better have those heels on the yard line.
You wore heels in the marching band?
No, just white foam-heeled shoes. Yeah.
White foam-heeled shoes.
Yeah, those of you in band know exactly what I'm talking about. And you had your white shoe polish that you had to polish them up, Anyway, this seems like a great place to kind of wrap it up for today. We've got a lot of other podcasts that go into these topics in great amount of detail, both on cardiac arrest, resuscitative cesarean, amniotic fluid embolism. Don't forget the AFE Foundation. We have partnered with them and created a free online course that provides continuing education credits for nurses and physicians and anyone. That's at afesupport.org if you want to learn more about it. But listen to our other podcasts on these topics. We're going to have more questions answered in future topics. You guys were awesome. And you can keep posting questions if you want. We love your questions and your feedback on this. So thanks everybody for listening. Don't forget to subscribe, leave us a review, and learn more about our Critical Care OB Academy and our company at clinicalconceptsinob.com. You can follow us on our socials at Facebook, Clinical Concepts in Obstetrics. We're the same on LinkedIn, and we're at Critical Care OB on Instagram. Thanks for listening.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.